Good morning. So, for our teaching rounds today, I've put together this visual explainer deck to systematically break down two pretty complex viral hepatitis admissions that came onto our medicine service overnight. As the senior resident, I'm going to present these cases to you and defend my reasoning for their immediate management. Now, viral hepatitis is one of those tricky topics, right? Rote memorization of antigens and antibodies just fails us at the bedside. To actually manage these patients safely, we have to understand the precise pathophysiology driving the serology. So, we're going to use this explainer to completely unpack viral hepatitis, moving from basic transmission principles all the way up to some very specialized treatment pathways. Let's jump in.
The big challenge on the wards is that a single positive marker can mean completely different things. It can represent lifelong immunity, or it can indicate a silent, chronic infection that's just poised for catastrophic reactivation. And this explainer is really designed to prevent us from misinterpreting those critical nuances. In clinical practice, we're constantly ordering these viral hepatitis panels. Sometimes it's for a patient with acute jaundice, and other times it's just routine screening before starting a new medication. As we review these two overnight admissions, I want you to keep this dichotomy right at the front of your mind. We're going to see how relying on just a superficial understanding of these blood tests can lead to major medical errors, and how a rigorous step-by-step interpretation can literally save a patient's life.
Okay, let's look at patient 1 first. He's a 34-year-old gentleman, born in East Asia, and he has absolutely no symptoms. No known liver disease at all. He was admitted for a hematologic malignancy and got screened before starting rituximab. His surface antigen is negative, and his anti-surface antibody is negative. But his IgG anti-core antibody is positive. His ALT is completely normal, and his hepatitis B DNA is undetectable. Then we have patient 2. She's 28 years old, 30 weeks pregnant, and she just returned from rural South Asia about 4 weeks ago. She started out with nausea and malaise, and that progressed to frank jaundice. Her labs are, frankly, terrifying. Her ALT is 1100, AST is 900. Her bilirubin is 6.2, mostly direct, and her INR is 1.6 and steadily rising. We've ruled out the usual suspects. Her IgM anti-hepatitis A is negative, surface antigen is negative, and hepatitis C RNA is negative. Now, I know your immediate questions are going to be, what exactly does this isolated anticore mean for patient 1's rituximab timeline? And for patient 2, why is that rising INR the single most alarming number on her entire panel? We're going to address both of those right now.
This table brilliantly illustrates the absolute foundational rule of viral hepatitis. The fecal oral viruses, that's A and E, do not become chronic in immunocompetent people, but the bloodborne ones, B, C, and D, absolutely can. Now, the word immunocompetent is doing a lot of heavy lifting there, and it's a pivotal caveat. Hepatitis A and E are transmitted via contaminated food and water. They have short incubation periods of a few weeks. When an otherwise healthy person catches them, they might get very sick acutely, but they will eventually clear the virus. There's no chronic carrier state. On the flip side, hepatitis B, C, and D are transmitted via blood, sexual contact, or perinatally from mother to infant. Because of how they interact with the host immune system, they possess the very dangerous capability of establishing long-term chronic infections. Hepatitis C is notorious for this, with up to 85% of acute infections becoming chronic. Understanding this basic route to chronicity relationship is really our first step in differentiating massive acute elevations in transaminases from insidious smoldering chronic disease.
So, to solve our first case, we must take hepatitis B serology apart piece by piece, starting with the antigens and DNA. These tell us if the virus is present and actively replicating. The hepatitis B surface antigen, or SAG, is the hallmark of infection. It actually appears before symptoms even start, which is exactly why we use it to screen blood donors. If a patient's surface antigen remains positive beyond 6 months, they have, by definition, progressed to chronic hepatitis B. Next, we look for the E antigen. The E antigen is evidence of active viral replication. When it's positive, the patient is highly infectious. But you have to be careful here. There is a specific mutation known as a precore mutant, where the virus actually cannot manufacture the E antigen, even though it's replicating furiously. Keep that footnote in mind. Finally, we measure the hepatitis B DNA. This is our quantitative measure. The exact viral load tells us how actively the virus is multiplying in the liver, and that directly correlates with the patient's risk of progression to cirrhosis and hepatocellular carcinoma. Now, what's really interesting here is the core antibodies. The golden rule to remember is that IgM means now. IgG alone means before, and an anti-core antibody is never produced by a vaccine. This is a classic pitfall in the wards. The core of the hepatitis B virus is highly immunogenic, but it's deliberately not included in the standard recombinant vaccine. Therefore, if you see an anti-core antibody on a panel, That patient's immune system has encountered the actual, live wild-type virus at some point in their life. The IgM anticore is the very first antibody to appear, and it's the definitive marker of an acute infection. As that acute phase wanes, the IgM gets replaced by IgG anticore, which remains positive for life, permanently marking a past infection. Finally, we have the anti-surface antibody. This is our protective, neutralizing antibody. If it's positive, it means the patient has either successfully resolved an acute infection and achieved natural immunity, or they've been vaccinated. If they were vaccinated, the anti-surface antibody will be the single, solitary positive marker on their entire panel.
Let's see how this all builds into the complete panel, state by state, and I want to pay special attention to the window period. During an acute infection, the surface antigen is positive and the IgM core is positive. But as the immune system starts to really fight back, the surface antigen drops below detectable levels, while the protective anti-surface antibody just hasn't climbed high enough yet to be detected. This is that dreaded window period. If you only check surface antigen and surface antibody during this time, both are going to come back negative, and you will completely miss an active hepatitis B infection. The only clue you have is that positive IgM anticore. Moving down, a resolved infection shows a negative surface antigen, a positive protective surface antibody, and a positive IgG core antibody proving past exposure. You might also see the anti-E antibody, which signifies waning viral replication. An immunized patient, again, has only the surface antibody, and a chronic patient has a surface antigen that stays positive indefinitely alongside a positive IgG core antibody. Notice that in the chronic state, it's the E antigen and the DNA levels that determine whether they are in an immune active or immune inactive phase.
Okay, so why do some clear it and others don't? The single most important number regarding hepatitis B chronicity is the age at acquisition. While under 5% of adults become chronic, over 90% of perinatally acquired infections do. This stark contrast is entirely about the maturity of the host immune system. When a healthy adult is exposed to Hep B, their mature immune system mounts a massive, aggressive response. They might get super symptomatic with jaundice and severe right upper quadrant pain, but that vigorous immune response clears the virus more than 95% of the time. However, when an infant acquires the virus perinatally from their mother, their developing immune system essentially recognizes the viral antigens as self. It just doesn't fight back. This leads to a state of immune tolerance, where the virus replicates to astronomically high levels without causing immediate acute inflammation. Because the virus isn't cleared, over 90% of these infants become chronic carriers. This sets them up for a lifetime risk of cirrhosis and liver cancer, and it's exactly why we aggressively screen pregnant women and vaccinate infants immediately at birth.
Before we get back to our specific cases, there's one more crucial point. While hepatitis E is typically a self-limited fecal-oral virus, it carries a catastrophic 10 to 20% mortality rate in pregnant patients. Hepatitis E is the most common cause of acute viral hepatitis in endemic areas worldwide. For the vast majority of people who catch it, usually through contaminated water, it causes a mild, self-limiting illness very much like hepatitis A. You feel terrible for a few weeks, your transaminases spike, and then you get better. But pregnancy fundamentally alters the host's immunologic and hormonal environment. When a pregnant woman, especially in her third trimester, contracts acute hepatitis E, the virus can trigger a rapidly progressive fulminant liver failure. The exact mechanism is still being debated, but it's believed to involve a shift in the mother's cellular immunity coupled with incredibly high viral replication. This statistic, a literal 1 in 5 chance of maternal death, is one of the most frightening numbers in all of hepatology, and it is exactly why I am so incredibly concerned about our second patient.
So, with our serologic framework firmly built, let's assess these two patients and lock in a definitive treatment plan for each of them.
For our first patient, the 34-year-old starting rituximab, that isolated IgG anticore means past infection. And because the virus persists in hepatitis as covalently closed circular DNA, giving him rituximab can cause deadly reactivation. Here is the exact pathophysiology behind this finding. He has a negative surface antigen and an undetectable viral load right now, which means his immune system is currently keeping the virus perfectly in check. His anti-surface antibody has simply waned to undetectable levels over time. But hepatitis B is a sneaky DNA virus. Even after clinical resolution, the viral genome persists inside the nucleus of his liver cells in a highly stable form called covalently closed circular DNA, or cccDNA. It just sits there, dormant, suppressed by his immune surveillance. Rituximab is a monoclonal antibody that profoundly depletes B cells. If we give him rituximab for his lymphoma, we will absolutely obliterate the very immune surveillance keeping that cccDNA dormant. The virus will wake up,
replicate uncontrollably, and he'll develop acute, potentially fatal liver failure. This is classic occult reactivation risk.
Therefore, my plan is to initiate a first-line nucleoside or nucleotide analog immediately, prior to the oncologist's first dose of rituximab. We must continue it throughout his lymphoma treatment to prevent acute liver failure. We absolutely cannot wait for his ALT to rise or for his hepatitis B DNA to become detectable. By the time those markers turn positive, the viral reactivation cascade has already begun and massive liver damage is underway. We're going to maintain this antiviral blockade continuously during his entire chemotherapy regimen, and we'll keep him on it for a substantial period, often 6 to 12 months, after the immunosuppression ends because B-cell recovery takes a long time. Throughout this process, I'll be checking serial ALTs and HBV DNA levels just to ensure our prophylactic net is holding strong and that absolutely no viral breakthrough is occurring.
So, which drug do we use? You'll choose from one of these 3 first-line agents, balancing the patient's renal and bone health against their prior antiviral exposure. For our patient, we need a drug with a high barrier to viral resistance and really potent antiviral activity. Entecavir is an excellent, well-tolerated nucleoside analog. Its only major pitfall is if the patient has a history of lamivudine use, which can predispose them to cross-resistance, though that's not the case here. Then we have the nucleotide analogs, the tenafavirs. Tenofovir disoproxyl fumarate, or TDF, is incredibly potent with essentially no known viral resistance to date. However, its long-term use is associated with a small risk of bone mineral density loss and renal dysfunction. To mitigate this, we now have tenofovir alafamimide, or TAF. TAF delivers the exact same antiviral activity directly to the hepatocytes, but circulates at much lower levels in the plasma, which vastly improves its bone and renal safety profile. Given our patient is going to be undergoing intense chemotherapy, I'm recommending we start him on TAF or entecavir to minimize any additional renal strain.
Just to contextualize this decision for your broader practice, keep these 6 standard indications for hepatitis B treatment in mind, because we definitely don't treat every chronic carrier. It's a really common misconception that every patient with a positive surface antigen needs antivirals. In reality, we only treat when the virus is actively damaging the liver or poses an imminent threat. We treat the immune active phase, where ALT is elevated and DNA is high. We treat E antigen negative chronic hepatitis if they have significant viral loads and inflammation. Crucially, if a patient has progressed to cirrhosis and has a DNA level over 2,000, we treat to halt progression. If they have decompensated cirrhosis, we treat immediately, regardless of the DNA level. We also treat acute liver failures stemming from acute Hep B. And finally, the special populations. Just like our patient facing immunosuppression, we also preemptively treat 3rd trimester pregnant women with viral loads over 200,000 to prevent transmission to the infant, as well as patients with hepatocellular carcinoma or concurrent hepatitis C.
Moving over to our pregnant patient from rural South Asia. The exclusion of A, B, and C paired with her travel history makes this acute hepatitis E. She came in with classic viral prodrome symptoms, the nausea, the malaise, followed by deep jaundice and sky-high transaminases in the thousands. That massive cellular necrosis points away from chronic disease and directly toward an acute viral insult. We checked the standard panel. Her IgM for hepatitis A was negative, her surface antigen for hepatitis B was negative, and her hepatitis C RNA was negative. But we have to be clinical detectives here. She just returned from an endemic region. The 4-week timeline perfectly fits the incubation period for a fecal oral virus. Therefore, this is acute hepatitis E until proven otherwise. To defend my diagnosis, I've already sent off the specific serology to confirm. We're waiting on the IgM anti-HEV antibody and the HEV RNA PCR, but given her rapid clinical deterioration, we have to act on the presumptive diagnosis of acute hepatitis E right now while we await that confirmatory RNA PCR. Because her rising INR represents failing synthetic liver function, she is in acute liver failure territory and must be transferred to a transplant center immediately. I want to highlight exactly why her lab panel is so alarming. High transaminases just mean liver cells are dying. But the INR, that measures the liver's actual ability to synthesize clotting factors. An INR of 1.6 that is actively rising means her liver is completely losing its fundamental synthetic capacity. Coupled with her pregnancy, she falls right into that terrifying 10 to 20% mortality bracket. My management plan here is aggressive. We are admitting her directly to the ICU and consulting high-risk obstetrics and hepatology. But more importantly, because we have absolutely no specific safe antiviral for hepatitis E in pregnancy, our management is purely supportive, making immediate transfer to a transplant center our only definitive safety net right now. We'll monitor her serial INRs and her mental status for any signs of hepatic encephalopathy every single hour while we arrange that transport.
Now, since we've extensively covered B and E, I know you always ask us about this on rounds, so I have to give you the hepatitis C counterpoint. Never confuse a positive antibody with immunity, because only the RNA test confirms an active infection. I want to make this distinction crystal clear. With hepatitis B, we have protective surface antibodies. With hepatitis A, the IgG grants lifelong immunity. But hepatitis C is entirely different. The hepatitis C enzyme immunoassay antibody becomes positive about 6 weeks after exposure, but a positive result does not mean the patient has recovered, and it absolutely does not mean they are immune from getting it again. It simply means the immune system met the virus at some point in the past. To know if the patient is actually infected and requires treatment today, we must check the hepatitis C RNA. The viral load is positive within 2 weeks of exposure, and it is the sole marker of active ongoing infection that dictates our clinical pathway.
The incredible news for hepatitis C is that our modern, pan-genotypic, direct-acting antivirals cure over 90% of patients in just 8 to 12 weeks. We have literally revolutionized the management of this disease. For adults with chronic hepatitis C who do not have decompensated cirrhosis or complex co-infections like HIV, we can use a wonderfully simplified treatment pathway. We don't even need to wait for genotype testing anymore because these oral regimens hit all genotypes, 1 through 6. We can prescribe a combination like sofosbuvir and velpatasvir for 12 weeks, or glycoprovir and pibrentzesvir for just 8 weeks. The side effect profile is remarkably mild compared to the old interferon days. Our goal here is a sustained virologic response, or SVR. This is defined as having absolutely no detectable hepatitis C RNA 12 weeks after completing the course of therapy. If they hit that mark, they are functionally cured, vastly reducing the risk of cirrhosis and hepatocellular carcinoma.
And briefly on hepatitis D, remember it requires hepatitis B to survive, but catching them both together is far less dangerous than catching D after you already have chronic B. Hepatitis D is this tiny, incomplete RNA virus that relies entirely on the hepatitis B surface antigen machinery to assemble itself. Because of this, it can present in 2 distinct ways. If a patient acquires both hepatitis B and D at the exact same time, say from a single contaminated exposure, this is a co-infection. It typically presents as a severe acute illness, but impressively the immune system manages to clear both viruses in more than 80% of cases. However, if a patient is already a chronic, stable hepatitis B carrier and then they are exposed to hepatitis D, this is a superinfection. The D virus hijacks the ongoing chronic machinery, leading to a massive acceleration of liver damage. It drastically speeds up the progression to cirrhosis and significantly increases the risk of hepatocellular carcinoma. This is precisely why we must check a total anti-hepatitis D antibody at least once in every single patient we see with chronic hepatitis B.
Okay, to wrap up my presentation with this explainer deck, I want to reiterate the 4 high-yield principles driving our management today. These are the rules that will keep us from making dangerous clinical errors. First, across all viral serologies, IgM means the infection is happening right now, while IgG alone means the infection happened in the past. Second, if you see an anticore antibody on a hepatitis B panel, that patient encountered the live wild-type virus. The vaccine only ever gives you the surface antibody. Third, never look at a positive hepatitis C antibody and tell the patient they're immune. It just means they were exposed. You have to check the RNA to know if they need our direct-acting antiviral cure. And fourth, as patient 1 proved, you must aggressively screen for hepatitis B before deploying any heavy immunosuppression like rituximab, anti-TNF agents, or prolonged high-dose steroids. Missing that isolated anticore can turn a routine chemotherapy admission into a full-blown acute liver failure code.
Ultimately, understanding serology isn't just rote memorization. It's life-saving detective work. So what other subtle clues might you be missing? We've seen today how an asymptomatic patient carrying dormant cccDNA needs preemptive antivirals, and how a rising INR in a pregnant traveler demands immediate transfer for transplant evaluation. The liver is an incredibly resilient organ, but when it fails fast. Every time you pull up a set of labs on morning rounds, don't just look for the obvious red numbers. Look for the absence of protective antibodies. Look for the discordance between normal transaminases and failing synthetic function. Our job as clinicians isn't just to treat the acute crisis right in front of us, it's to anticipate the storm before it breaks. As we go round on the rest of the service today, the question remains, are we just checking boxes on routine panels, or are we actively reading the story the immune system is trying to tell us?